Okay, and we are now live. And hello, everybody. Thank you so much for joining us this morning, this afternoon, depending on where you're connecting in from. Uh, in today's session, we have a very exciting panel discussion regarding digital transformation in aged care. We've got some great panelists joining us today, looking from both PainChek, where I'm from, as well as, of course, our partners at VCare and a provider that I'm sure you're all familiar with, Summerset, one of the leading aged care and community care providers in New Zealand. So before we actually get into everything, we're going to begin with a quick introduction from our presenters, whose details you can hopefully see just on the right of that slide today. So first off, you're at the top of the list. I'll just start with you, please. Lynda, if you wouldn't mind introducing yourself.
Sure. Hi, everybody. I'm Lynda Irvine. I'm the Head of Clinical Services for Summerset in New Zealand currently, and operating in Australia sometime in the near future. I've been with Summerset now for 5.5 years, and I've been doing aged care for over 30 years now, in actual fact. So, you know, as I often like to say, I started when I was about 6, but that's not really true. But it's a very strong passion of mine, and I've worked in all areas of aged care, both in inpatient settings, community settings, general practice, and aged residential care. Yeah, so nice to be on the call, and thanks for the invite.
Thank you so much, Lynda. We'll now pass over to Elizabeth, to Liz.
Hi, I'm Elizabeth Lear. I'm a registered nurse, and like Lynda, I've been in aged care a long time. I'm the clinical and quality manager here at VCare. Yeah, had lots of experience within aged care, from both the practical side of being the RN on the floor, the educator, the clinical manager and facility manager, and also an auditor as well.
Right on. We absolutely love the experience, and Liz, just like Lynda, I know that you're being quite humble with that introduction. We'll now pass over to Catherine Smith.
Hi, everyone. I'm Catherine, and I'm one of the clinical consultants here at PainChek. I've been in aged care for about half the time of Lynda, so about 14 years. But I started my nursing career as a carer, and then I did my nursing training as an endorsed enrolled nurse. So I used to work at our local public hospital. I had a permanent position on the surgical ward, but I really knew that my calling was always aged care. So I went back to residential aged care. So I worked on the floor. I've held positions as an ACFI manager and also quality and compliance manager. And also I've conducted audits for homes who had non-compliances and sanctions, so from a consulting capacity. So lots of experience with change management and helping organisations move through all of those structural changes and difficult times that they come up against during those times that they spend with the Commission. So yeah, really happy to be here today.
Thank you, Catherine. And lucky last, David Allsopp, if you wouldn't mind giving yourself a quick introduction as well.
Of course, thanks, James. Good morning, good afternoon, everyone. David Allsopp here from PainChek. I'm the Head of Business Development for PainChek across Australia and New Zealand. My background, a bit like Catherine, my 20 years spent in aged care doesn't really compare to Lynda and Elizabeth, but I've been working in the aged care sector across Australia and New Zealand for 2 decades now, coming up. I'm a physiotherapist by original degree and worked clinically as a physio in aged care, but the last 10 years of my career really been focused around technology and innovation into the aged care space across Australia and New Zealand, mainly focused on residential aged care, and really thrilled to be here today.
Absolutely. Thank you so much, David. So now I'm just going to make sure that everyone attending today can actually see you all. So hopefully that's all coming through well. But to start off our session today, knowing that we have a group of very experienced clinicians, people with deep roots in the aged care industry, I want to start off with just hearing about how you've seen technology change over your tenures in the industry. We know there has been a huge amount of change over the last 5 years, let alone the last 10, 15, and as we heard, plus. I don't know if anyone wanted to kick off potentially yourself, Lynda, if we want to stick to that same little format as we get going.
Sure. I think certainly with technology, it can be very much a kind of a gradually then suddenly process, can't it? That you're watching, and then bang, it's ready, and then it's about when you adopt. So traditionally in healthcare, we are quite risk averse around technology and making the change. So in some ways, when you look back, you think, goodness me, some of the stuff, why didn't we do it sooner? So certainly some of the electronic medication charts and administration systems have greatly reduced risk for residents in aged residential care. And I think in New Zealand, we now have perhaps one provider who operates paper charts now. And so some of those innovations have really been groundbreaking, I think, and certainly electronic patients or residents, however you may see, has been groundbreaking as well, and always developing. So it's always about, have you got the best? Are you up with the play? Is it meeting your needs without chopping and changing? But certainly I see some of those developments have been a great step forward. And I always kind of relate back to our caregiver roles, our mostly unqualified workforce in terms of professional qualifications, and once they have an electronic system, you can easily understand what they're saying. Their words are gold. They really contribute well to resident care, and there's sometimes been this risk aversion around, will people use the system? Much better than handwritten, much less open to interpretation, and can always be understood. So they have just a couple of very rudimentary examples in aged residential care now, and a long way to go, I think, but definitely it's time to move with a bit of scale and pace, I think, and in terms of embracing technology to support resident experience of care, safety and care and efficiency. So
no, absolutely. And I guess that risk aversion seems to be such a big theme, what you're saying, and like with those big opportunities. Liz, have you seen that similar trend in your tenure?
Yeah, I think, well, all change. We're creatures of habit, and people don't tend to like a lot of change. So it's just encouraging and embracing the changes that are coming, and making sure that they're aware of the reasons for the change is really important. I mean, certainly the move away from to paperless systems and electronic patient management systems and electronic medication charts, that really has grown in the last 10 years, definitely. And as with all things, once they've actually implemented it, like Lynda says, they say, oh, well, why didn't we do that earlier? When they realize the ease of use and the time efficiencies it saves and the lack of duplication, certainly that's been my experience, is that they think, oh, why didn't we do this earlier?
Absolutely. And Catherine, your thoughts?
Yeah, I just wanted to touch on the points that Lynda mentioned about risks as well, because I think the impact of technology has really been that we can enable this transparency across what is actually occurring right down to a care level. So it can ultimately have that flow-on effect to really helping us identify those high impact and manage those high prevalence risks as well. So even though there is that apprehension there and the reluctance to make that change, that if it's supported well, it can really have that flow-on effect to ultimately impacting not only at the care level for the employees using it, but down to the resident level as well.
Absolutely. I want us to really come back to those care outcomes right at the resident level that you've highlighted there, Kath. Before we pivot across though, David, did you have anything to add just as we get started?
Yeah, that's a couple of quick things. I think this kind of does come into line with what Lynda was saying too. I think in my 20 years in the sector, I've seen us we sprint and then we pause, go, okay, let's embrace technology, let's slow down, get our bearings again and sprint again. I think what has happened last, I suppose, 5 years, and I think, during a pandemic, you've got to try and find some silver linings because it's been really tough on the sector. There's no doubt about that, and across globally, as you all know. but it's made us to be more focused around how can we digitize, how can we use innovation and technology to better serve our clinical outcomes or endeavors. And I think that's a lens that I'm seeing right now in my experience that we're looking through and moving forward. If it can benefit clinical care, and that can be as simple as, okay, this is going to help giving clinicians more clinical time. It doesn't have to be the most impactful, bolshy statements that we're hoping to drive through technology, but it can be simple little things. And I think if there's a benefit or a silver lining, like I said, through the pandemic, it's made us lean in more. And I think hopefully we'll see a nice acceleration. I think one more quick thing, I think early in my career in aged care in probably the early 2000s, it was we were very much the laggard in healthcare. Aged care was always the last to get to innovation and technology. And I think that's probably been the case like I said, with those sprints, but I think that is changing now, that landscape changing, that we keep up with healthcare innovation in general, which is really exciting for our sector.
Absolutely. And guys, I'd love for us to think about just some of those. We've heard about the opportunity that we've got in focusing on optimizing care outcomes through this sort of transformational change that everyone highlighted, managing risk and really leveraging technology and how it has been leveraged to date. With that sort of digitization, does that necessarily flow directly to better care?
I'll kick off, will I? Just because we'll keep the order of events going. But I think there are some changes that just naturally deliver really well, don't they? And then, as you say, it is that bit of a pause and then a resprint. So if we look at some of our electronic charts, for an example, there was quite a significant reduction in medication errors in aged residential care, just with the implementation of that. But then there's now this opportunity to go back and circle around and keep growing the benefits out of the system and honing them in even more. And sometimes it can be hard to progress that aspect of it. So there's a lot of functionality that you can stretch and use, and it always comes with that education and people using the system, understanding the benefits and the value proposition, I think is always important to drive change. So for your prescribers and for your nurses administering and caregivers as well, it's really about what is the other functionality that will continue to help grow those benefits. So I think that's a really important aspect, but putting a system in alone won't do that. And I think, if we use PainChek as an example in Summerset, we did a good rollout nationally last year, and that's a system now used. The policy is set. All of those jolly good things are in place. The training's excellent, and it was a nimble technology that people embraced. But we are now still making sure that we're driving that uptake and getting that stretch out of it to say, is it actually being used to improve pain assessment and management for our older people? So it's a constant thing. And I think sometimes when you've got so much on your plate, it's easy not to keep up with that stretching, that change management past that implementation point and cycling back. And I think some of the virtual assessments that came into play very quickly with COVID, with general practice, had delivered some great results at the time, but now we have to do a circle back now and think strategically, well, actually, where does a virtual consult fit for resident care? Where, most importantly, may it not fit? And making sure that you're applying that appropriately and that you have covered off all of the risk points and you do have a safe process around that. Because when I speak about risk aversion, I don't mean that it's about being too scared to embrace change, but it is the time that it takes to work through the risks, which in health is quite a thorough and robust process, as it should be, I believe. So yeah, I don't think it's automatic, and it's something that you have to keep working on. I think, and you get a certain lift out of a straight implementation, like we probably experienced that, I think, with VCare, just in terms of, like, for me, being able to read those progress notes so easily was gold. And then you've got to keep stretching what other benefits you want out of the system and the user experience and the user knowledge. Yeah. So that would be my kind of comment there for a pause.
Absolutely, and anyone, please feel free to jump in.
Yeah, I think I just wanted to mention there that when we are implementing technology, that ultimately, I think at the start, it's great to think about what do we actually want to achieve out of this and what is our ultimate goal. That even though there is all of those problems that any project will come up against, whether it is implementing technology, if we have an ultimate goal or a goal in sight as to what do we actually want to achieve by embedding this, I think that can drive that improvement and just really help us to keep going throughout all of those the roadblocks and the things that we come up against in any project.
Right on. So I feel like at this point, we're sort of almost thinking about that, the workforce side of things, the change management, how we actually implement a change that we've come to. Are there any, I know that you definitely have some, when we're talking about that risk management, as you highlighted, Lynda, that very thorough review thereof, and I guess communicating to your teams, that review has taken place and we've identified improvements and opportunities. Are there any sort of strategies group that really jump out at ways that you've been able to support teams through those, whether those are complete transformational changes or more smaller iterative changes? What are some things that have sort of worked well for you, or things that our participants should be looking out for when they consider these sorts of changes?
I think for us, it's really about making sure that the value proposition is really clear so that people want to embrace the change, and staging training and support so that people have enough to get started, can still cycle back when they're actually becoming users in a nimble and agile way that spans the needs of the business, so not 9 till 5, Monday to Friday. And I think, going back and doing that refresh, because you do tend to get people have learnt something in the heat of the moment or the first training rounds, and that's what they know and understand, and then they carry on and use, and then you can get some of the workarounds creeping in, or they're doing things a longer, slower, harder way because that's what they learnt at the time, and we haven't really got the framework there to make sure that we're refreshing people's knowledge. So a lot of strategies can really help with that around having good access to ongoing training and support, having tips and tricks and bulletins and updates and things just to remind people this is the easiest way to do this is the easiest way to do that, having a quality framework around it, so making sure that you have got some internal auditing, reporting, that you're actually seeing how users are using the system and applying it. All of those things will help close the loop, as well as looking, depending on the technology and the appropriateness of it, around the customer and their families for us as well, any feedback around those changes there being incorporating back in. And then I think once again closing that loop back to your frontline teams and showing them the benefits of the change and how that's tracking, I think is really important. And as I say, it can be very easy to front load all of that change process, and then perhaps even a year down the track you've really got to go back and say how are we tracking now. And I think the other comment I just wanted to make, which might not quite fit here, but it's just, I think one of the things that can be quite a challenge for providers is the mix of organisations and ability they have to assess and scope and embrace and fund some of these electronic or digital transformation initiatives. And so we have a range in New Zealand of small providers, large providers, and I know in Australia there is as well. And older people in both of our countries need the benefit of that choice, but it can be much harder for those smaller providers to be able to embrace some of these transformational changes as easily as it is for bigger organisations, where we have got a structure and specialist roles supporting the development work around this. So I think that's something that maybe some of the companies that are offering solutions could think about, of how they can actually help the sector come together to support each other with that.
Yeah, I definitely agree with you there, Lynda. And I think because we know that we all work or have worked with a range of different types of providers, whether they're small or big, is that one thing that works at one home may not necessarily work the same way at another home. Doesn't mean that it can't work. It might just need a different approach, or a different approach to the culture change that we embed at home, a different approach to the education around that project management. So yeah, I'm really glad that you mentioned that as well, because even though one thing might work somewhere, it might just work differently somewhere else.
Yeah. And how you could share maybe some of the costs or the resources around smaller providers networking and embracing some of the change, because maybe if you say, for instance, had a help desk line for a system that they could share that some of that sort of opportunity, and that's not an easy thing to do, but there are different ways, I'm sure, across the systems where providers network, that could be a way of helping reducing those barriers.
Yeah, absolutely. Because I think now we're doing a whole lot more with a whole lot less. So yeah, ideas like that are fantastic.
Yeah.
I think just to jump in on that too, and Lynda's point, what really resonated with me is around, we work in a sector that is very humanised. We're dealing with people at the latter end of their life. Care is why we're here. And I think to that point, it's around the technology's got to serve better clinical outcomes, efficiency, etc. But the support that Lynda mentioned, we're very lucky to have some great resources like Catherine, who've got clinical expertise to offer. We've got a great technical support team. So things like that, I think the technology is at the core of what you provide, but as the services that you wrap around that to make the experience, the change management, the engagement really, really fulfilling and really, really beneficial. I think Catherine made a really good point before around keeping the end goal in mind and rolling out technology. As we all know on this call, there's generally often and more often than not a few little bumps on the road, and that's just around change management or different processes, etc. But I think Catherine's point was so powerful around this is where we're trying to get to, and this is the road we're going to take. It's not going to be a straight line, but by having great support around the technology in a humanised industry, I think goes a long way for having a great, successful piece of change management and embracement of new technology that can benefit resident care as well.
I think it's also important for people seem to think that a system is perfect from the beginning, but it's about that continuous improvement. So, what we might start with, we actually might think, and once we've used it for a period of time, we might then decide, oh, well, no, this could be improved by doing this. So those changes are made, and it's never static. As you know, quality is always a moving target. And I think it's important for them to realize that that's part of the process, is learning and then implementing those changes to make those improvements to get those results that we need and the outcomes for our residents as well.
Yeah. I think also too about understanding some of the barriers to adopting change. And I know even with us with PainChek, there was a tendency for individuals to think, well, I'll just check the old way and just to see if it came out the same, and so you really have to work with people around their own professional safety, really, to understand that you've kind of done all that work ahead of that, and it's quite safe for them to make the change and not to spend their time going back using their paper Abbey scale and seeing if it came out the same as the PainChek app, so, but I think that's important, because that is something that as individual practitioners that you're responsible for thinking through for yourself. So I think that is a useful part of the change, is just to understand the barriers for people and then how you can actually support them to know that you've got their back on that front with the change as you're rolling it out. Yeah.
I think also from a support perspective, identifying those champions, with on each ward or on each shift, that can assist others who maybe have not picked up those changes or the system as quickly as others, so that they're there as a great support for them, right? And on site, is also a good thing to identify and help the rollout of whatever system or improvement project that you're running.
Absolutely, because I'm absolutely loving this conversation, by the way, hearing about some of these various perspectives there. So in terms of that, we've got some really clear ideas about the sort of support that we want to be able to provide to our end users as we make those decisions, or as we implement those new improvements. But stepping, I guess, up a level from that, I guess, Lynda, particularly in your experience as that extremely senior clinician executive in a business, and a question more generally for the panel. When you're being introduced to new technological changes, or call them what are presented to you as modernization generally, Are there some major factors that you need to consider in the current landscape, be that regulatory, financial, anything else that really goes into and informs your thinking there?
I think it's really, for me, around all of those stakeholder views and issues that we face around that. And I think some of the major factors that we look at in particular is, firstly, will it improve safety and experience of care for residents? Because that's the reason why most of us come to work in this sector, is to deliver that really excellent care. So we do look at that. And then workforce benefits now are very much a driver for us all, because the workforce will continue to be scarce in health and aged residential care for some time. So actually making sure that your workforce is enabled to work at the top of their license, that the tasks and processes they're required to undertake add meaning for the work that they do, is really important around that. And then that efficiency and some of the gains that may be made at a local and a company level are definitely the three key things that we would look at in terms of how we might look at a change. I'm not sure what else was the part of that question, James.
No, I think that question was about any potential factors that play into your decision making and review. So I think you've really covered that.
I think the other side of it that can sometimes get a bit mingled into change, which is important, and often you get a lift up. And as I say, sometimes a technology change is not meant to do all of the education and training around clinical practice or how we deliver care for residents. But sometimes you have to embrace all of that in the change management, because sometimes you are driving something that is going to be a best practice change, and you might want to make a practice change around that, and that might mean a change in culture as well. So it's about thinking through all of that and making sure you're clear on those things. So for PainChek, for us, we really want to make sure that residents living with dementia are not living with unmanaged pain. And so how do you actually build your education around people living with dementia, as well as the actual PainChek and then the pain policy, and all of those things come into play, don't they, to make that change successful from all of those factors. So it delivers that return on investment of time for the people doing the assessments, which is mostly our registered nurse workforce, but improves those outcomes for resident care as well, I think is really important. And sometimes when you're going through the change process, you are adjusting how people do the job or the task as you go. So it isn't just about the technology, is it? So you have to make sure you've got the right people involved that can deliver all of that, because that can become, then someone could train just in the technology, but that doesn't help with the process change. So if we look at some of the developments we're looking at around an app on a phone for staff to actually input at the point of care. One of the changes we want is for staff to spend more time directly with residents and not to be in an office writing notes. So that's a culture shift that we want the technology to help us with, but it isn't technically just about the technology.
Absolutely.
And that's a constant thing that you have to revisit, and go into sites, once you're embracing change like that and thinking, we're all having a wee gather in the office today. But it's a change for people to sit with a resident and talk to them about what they may be entering, as they rightly should. I'm just writing about how your shower went today. What do you think I should say about that? Is just more face-to-face time with residents, more interaction in their care. So that's not just about the app. It's broader than that. So that's where the change management, I think, has to be thought through end to end to make sure that you are driving those things and following up on them. A bit of a sideline benefit really from the actual technology itself.
Yeah, I love that you mentioned that about the resident, Lynda, because I think that even though we are, discussing what impacts our decision making, is that if we do bring it back to the resident, even though we are talking about a technology change, that ultimately we're having that additional consultation with the resident and having that greater connection and giving them that time. So yeah, absolutely. I think even though particularly it's about the technology, but then what will it ultimately give us in the end? Will it achieve a better outcome in our residents' well-being and their overall mental health by enabling us to spend more time with them and interact with them and sit in their room instead of our nurse's station, with something just so simple.
Yeah.
Absolutely. And group, I can say we have actually just had a question from the audience regarding examples of digital change that have made a difference towards patient care. And I think it sounds like you've just articulated one of those quite well. But just leave that open if there were any other sort of examples that you had front of mind that you might want to give from your experience of how that digital change that you've made or have supported has quite directly impacted on that care recipient.
I think I have mentioned that, just moving to the electronic medication charts, certainly saw that downturn in medication errors, which was a significant outcome for resident care, I think. With PainChek, it's a little bit too early for us to give any definitives back on that, but that's part of that kind of watching and growing and making sure we are looking for those benefits and they are being delivered for residents. And you can use a range of metrics for that. So we can look in New Zealand, of course, we use the Inter-Eye assessment for older people, and that has a section on pain. So we could look at our data from Inter-Eye by each of our villages around the country and say who is living with unmanaged pain according to our Inter-Eye outcome scores. So that can really help drive that, because that would be our goal, is that residents don't live with unmanaged pain. I think in terms of other resident care, I think it's a bit harder to say in a concrete way, but when you do move to an electronic management system and you have good access for wider care team members to be able to see and visualize resident records, that's really important. And that's quite interesting, as still a barrier to change for different people in different work environments wanting to connect via their own workflow. So if you're in a general practice or a primary care environment, you want to go into your system, and VCare, as our example, should be there. So some of that is taking a little time to establish, and then getting the practitioners to understand the value of reading the caregiver notes. So when they get rung off the cuff about a resident changing condition, you read the 72 hours of progress notes prior to that from caregivers is absolute gold. But that change management takes quite a time for people to achieve, and I believe can deliver a lot around resident safety and virtual consults. If you're using FaceTime, Zoom, whatever it is, to actually visualize residents and got access to their clinical records from the provider end, you can do a better assessment. So that should improve outcomes, I think. But yes, as I say, some of these changes take a wee while to deliver onto that scale that you want them to be. Yeah,
definitely. And I think that goes right back to a point you made at the top of the session, Lynda, around needing those constant touch points and reviewing your progress, and continuous improvement. Exactly as we say, it requires continuous sort of review and analysis to steer the way, if you will.
And a nimble approach around the integration of systems, because that's not as nimble. So one of the wise professors I worked with in the hospital once said, "Don't ask if it can be done, ask if it has been done." Because there is sometimes a lot of this, oh yes, we'll be able to integrate here and integrate there, and you might find yourself down the track quite some time and that you haven't quite achieved that. So I think that is something that can be exhausting in the sector, well, in health in general.
Just to add to that, team, I think, and apologies, it's not going to directly answer the question, but I think it is worth mentioning. I think coming from two lenses, I think Lynda made a really good point, going, I've not met a clinician or someone who's been trained in a clinical manner that wants to do more administration. They want to spend more time with residents. They want to deliver good care. They want to really that part of their job. And I've seen, in my experience, unfortunately, the last 20 years, probably clinically focused people being bogged down in administration. And I think we're addressing that now with some really good different systems process that Lynda and the team have touched on. But I think we need to think about it from the opposite lens too. And once again, Lynda, you referenced this, and this sounds a bit dramatic, but I do believe this is to be true. It's a real war for talent out there in healthcare. Like, how do we attract good talent to our sector? And by having archaic and archaic processes around the administration, that's not going to attract good talent to our sector. And when I say talent, that's new talent to our sector post studying, and keeping our talent that may not go into acute or go do something else. And I think innovation being at the forefront of that will attract talent in our sector too. And as we know globally right now, it is a real challenge attracting healthcare practitioners and clinical people. So I think kind of workforce lens and kind of, okay, the clinical more time of residence lens is two lenses I think that need to be looked at when looking at taking on technology.
Yeah.
I think that interoperability with different systems and the transparency for other GPs, nurse practitioners, pharmacists to be able to see the information that they need to guide their clinical decision making is really important. And I think that has had really positive outcomes for a lot of residents in aged care over the last, 5 years, definitely. I can definitely see improvements there. There are also improvements where when we want to help clinical decision making, we can prompt good clinical decision making through processes that we embed within our systems. So that helps guide practice and that consistency of practice within our teams as well, I think is really important to continue to improve those outcomes for our residents.
Absolutely. So we've spoken now, I guess, quite heavily about the outcomes that we're looking to achieve and how we can do that. For me, at least, the other core part, like there's your viability, your resident outcomes, but there's of course that sort of compliance piece, ensuring that we are meeting all required standards there. And I know that Liz, Catherine, and I'm sure Lynda as well, and frankly, this whole panel have some very, very deep experience in sort of managing that. I know we've talked about integrated systems and how bringing that data into a central point, with a system like VCare, for example, can really facilitate, care, clinical decision making, and everything that goes with. Can the same be said from the regulatory compliance side?
I can jump in there, James. I think from experience, when we are looking for information or what the story is telling us within documentation, where we're looking for the story about what has happened with this resident over the last 72 hours, if we see deterioration, we want to see transparency. So what's the story telling us across all of that documentation? That's where I think technology can really enable that facilitation, us to look at it across multiple systems and allow for that transparency to what's the story telling us that's happened within their care over that time frame. So yeah, for me, that's absolutely where I'd start from, particularly when we're looking at from a resident outcome.
Yeah.
I think from my auditing experience as well, that transparency within the electronic patient management systems and medication systems has been really valuable, because you can see the whole journey. You can see the whole patient journey. You can identify if there have been gaps, or you can identify where they've actually really provided excellent quality care. And I think it's important as well for, because often we focus on the negatives from an audit perspective, where we don't tend to celebrate those, the really good things that we're doing. So I think it's a really good way of saying to our staff, like, this is the audit I've done on this resident, this is great. You've followed policy and procedure, and celebrate those moments with them as well.
Yeah. I think the other thing I would add, which is probably a bit of an unintended consequence, but when we talk about being audit ready every day, certainly your electronic systems, you cannot hide from the data. So, that kind of, historical approach of, well, we'll tart up all the care plans because Liz is coming. You can't do that now. You've really got to have your systems nailed, because, your history will always be there. And that is good for transparency, and it does drive the practice that you need to actually deliver against the standards and to deliver the resident care. So it's got its pluses and minuses, as we say in the trade, hasn't it? Yeah.
Dude. So with those, I guess there's clear benefit, potential challenge, but we'll take it as positive challenge to really have that view and ensure quality is consistently maintained. Well, are there any other sort of comments that you might have around quality? or around those care outcomes. Otherwise, I want to start, having a next piece of this conversation about what the, what the future looks like for us as an industry.
I suppose the only other thing that I'd mention from a quality or outcomes perspective is that even though we might identify throughout, looking at the technology or looking at the documentation, even though we might see that there are gaps, well, what is it telling us about our process? What is that telling us about our staff education? So even though we might find something that's negative, it can effectively turn into a positive, because how can we now embed this as a continuous improvement? What's it telling us about education, our internal process? Do we have a clear policy around, say, pain management, for example?
And I think, working with your teams to understand the barriers, because, people don't come to work to not do the right thing or not to deliver the right care. So sometimes you've got to, really move away from a blame and train approach around this, and have a very open door policy and a high reporting culture that says that we're here to take a continuous improvement lens and to help people grow and improve. And then it might be, as you say, that you're asking too much in process or unnecessary steps, or there's other barriers in the way of compliance, and really important to have a really good, strong culture about that. And I think in New Zealand, I'm fortunate to chair an internal benchmarking group of about 13 other providers, and we share our events data, we share our inter-eye data as well, and we look to work as a sector as to how we can continue to drive improvements based on that sharing. And while you don't set a target to achieve with falls, it's very helpful knowing sometimes that if you're looking after very similar residents, that you are actually within line with your benchmark partners, or you may have an indicator that you're out of line with. It can help to drive that improvement change, and you might have indicators where actually you're doing really well and you can share that. So it's a very good open sharing environment about understanding how people have made those changes to drive those improvements for resident care. I think the more that we work as a sector, the better to collaborate.
Great. There's just one comment that you made there, Lynda, that resonated really strong. Well, lots of things you say have resonated very strongly with me, but in this particular case, I want to highlight, you made a comment about really developing, as you termed it, a high reporting culture amongst your team, rather than encouraging people to be really proactive and feeding back to the organization about what's working, what's not. Have you encountered any barriers in sort of developing that culture, or I suppose conversely, what things have really enabled that for you at Summerset?
I think, it's basically having all of our leaders sharing that same culture and driving that. So we call it our go forward, not back approach, so that people can feel that they can come and tell us whatever's happened. And as we say, we'll help you out of the rabbit hole, and then we'll figure out how you got there later. And that might be something that you can go back and address. But it is, I think, really important, but it does take time. It takes people testing it and trusting it. And then it takes even working with your leaders, I think, to go back and say, okay, if someone's made a medication error, why would you want them to repeat their competency? Because, that they will pass that. They pass it the first time, they will pass it the second time. So we're looking for more of that root cause analysis thinking, or a learning process around looking at human factors and systems and all of those things that start to say, as a human being, I came to work today to do a good job, and what happened for me that didn't occur on this occasion. And certainly it's really important, I think, to keep people's confidence in their practice up, because at a time when people make an error, their confidence reduces and they actually create more risk for themselves and for the residents. So you've really got to boost that, I think, is really important. And that does take time, and has to be across all facets of the care, I think, and across the whole network has to work in that same way. So that would be kind of my take on it, that's what we've worked hard at in Summerset to say. And the first thing our clinical governance board will ask if they see something that looks like it's made a dramatic improvement is kind of like, is everybody still reporting? So you have to be able to hand over heart and say that this improvement is real, or yes, this data may be ugly, but it is our truth. So that's the best way to have that open transparency and drive that continuous improvement culture.
Absolutely. It ties so strongly back into what we were discussing earlier, always making those training resources available, having those escalation points, those champions, and everything that goes with any sort of significant change, allowing people and supporting them to be confident, competent, and happy with the process as it's been sort of developed and designed.
And I think once you've developed that culture, you can then keep taking it to a next level. So in Summerset, we use the Power BI for our reporting, and the teams benchmark themselves against the Summerset benchmark. And I share the external benchmarking anonymized to say this is Summerset in the red, because you'd always want the best color. And here's the other providers here where we sit. This is our burning platform of opportunity here. So that's really good. And then now in some of our national work around our falls prevention, they are sharing their own data, even though it may be a massive improvement opportunity, and talking about what they're doing collectively. So none of us mind in Summerset sharing our data, even if it happens to mean that your village has got the most medication errors for the last 3 months. It's all about how we're improving them, as opposed to, oh dear, we're at the top of the food chain. This is not where we want to be. So that's the next level of that culture, and always being transparent about that. So emailing out the teams and saying, I want to send this out named villages. Is everyone comfortable with that? And sometimes if you have a really critical event, just allowing a bit of time for that team to kind of recover from that and do their own internal debrief and learnings. And then when they're ready, say, do you want to help with a case review? Can we share this nationally around our learnings from the situation? And that's a maturity level for the teams to say, yes, this happened for us, and this is what we're learning from it, and this is how we're looking to make improvements, and then sharing them nationally. So that's all. You have to have that safe culture before you can keep going to those next levels of trust, I think. Yeah.
Absolutely. Anything else from anyone at this point? Otherwise, I've got some exciting questions for you about, what are we doing next? I might dive in then. Lynda, I can see your lips are twitching a little bit there. So I don't know if you have anything that you want to jump in with right away.
Oh, well, about the no, I don't need to jump in first at all. I was just kind of looking to see if anybody else had any other additions. Don't want to be hogging the show.
No, Lynda, the insights are phenomenal. I'll jump in quickly, James. I think when I say I'll kind of come down a level here, and I think what I've seen in my experience in the sector, I think probably 10 or 15 years ago, we went, technology's coming, let's get best in breed everything. And then we got best in breed everything and realized it didn't communicate to each other. So this is kind of to Liz's point, going, the integration, the technologies talking to each other to behoove what we're trying to do clinically, reporting wise, etc. That is key moving forward. And I think for any providers on the call, if you're looking at taking on technology, that would be one of my key ingredients. How do you speak nice with other technology, whether that's our example, PainChek into big management, into clinical management system. That is not a nice to have these days. It's a must have moving forward. And I think that's one key piece of, you may go, okay, we need this technology, but when you vet in different vendors, that's a non-negotiable in my opinion, moving forward. And I think that's only going to, I think we've headed that way quite well over the last probably 4 or 5 years, but I think that's going to go from here to here moving forward too. So I think that's a key factor on what's happening moving forward with technology in our sector.
Yeah.
Absolutely. And I guess with that sort of changing of what is our focus as an industry for the technology that will best enable our clinicians to provide that high quality care and feed into all of our other requirements, I think there was one thing that actually, Lynda, and I'm so sorry to I know you don't want to take the spotlight too much. But this was a comment that you actually made to us the other week, I think. But it was around, what's the future look like? And I think I wrote it down because it really stuck with me. Advanced technology is sort of already happening now, and we can't only be thinking about the future and what's happening next. I think we've talked a lot today about how those things that we've redefined best practice in this day and age. We've been able to sort of make that change. But I think we know that, as we say, the future is happening now. There's a lot that we can sort of learn from other industries, as well as solutions like VCare and PainChek, which are sort of highly tailored to care. Are there things that you see outside, Liz, Kath, Dave, I know that you're always on the look, things that you see outside of our industry that we may want to look to emulate and begin bringing into, or may very well already be part of our operating models?
I think that's a very good analogy, because we were talking with in Summerset around a new incident reporting management, more focused on staff, and just looking at, I think it might have been a bank and how they've implemented the training there in a very simple process. So it was about drilling it down to actually the user and what level of information the user needed to be able to be effective with the technology. So then you grade it up as you get somebody who's more administering the system, or has a different role around investigation and has to have more access and understand more about the system. So I think certainly some of those things are really helpful. And even though I don't work in the community now, I can remember saying one time with the community staff, how come I can tell from Uber on my phone that my pizza actually got next door and they stole it, but I can't find the district nurse in the community when I need to get them back because there's an incident happening around them and they need to come back to base or get out of people's houses. So yeah, I think some of those things we don't really translate very well into how they could improve processes for healthcare. And I think that comes back to that healthcare risk aversion and that risk assessment process, holding us a little bit back from that, a little bit. So yeah, that's probably kind of my take on it, is that I think we do need to understand, to look more broadly around what are you trying to implement and deal with, and what kind of scale and who can help with that, because many other businesses and sectors have either the whole solution that they've already managed very well, or they'll have a part of the solution and you can work with the 2 or 3 different ideas to patch something in for what you need, rather than just kind of, shopping for one system to deal with one problem, or one improvement rather.
No, absolutely.
Yeah, but I think sort of managing the environmental landscape around this is a challenge. Even if you wanted to choose tomorrow a new resident electronic record system, there's a long job for everybody already, isn't it? So yeah, I just wish there were sometimes more nimble ways that you could assess the playing fields around things than there currently is.
No, right on. I guess just to that point, that sort of constant evolution and change, those nimble solutions, as it were. I'd love to pivot to you, Liz, just from that VCare perspective, because I know that a little bit selfishly here at PainChek, we've made some big demands on VCare. Demands, maybe not the right word, but knowing that integration is so essential, all of them. We've talked about this at length today, but VCare has been really nimble in how they've been able to pivot with PainChek and build in some really smart automations into that integration, triggering off alerts and different processes. How does VCare approach that changing landscape?
Well, I think we're always trying to keep ahead of the game, but it's also about asking the questions about what the needs are from the client in particular, because everybody has different needs, and it's trying to find a way to integrate and implement systems that actually meet their needs and the needs of their clients, because the processes are different and the demographics are different. We're really fortunate, and the system is able to integrate with many other apps and systems like MedTech, Enterprise, electronic patient medical charts, so there is the ability to do that, and it's just trying to keep ahead of the game all the time, but it's seeing what's needed. We're trying to predict the future, and we're trying to look for what is going to be the need in the future and find the solutions for that for our clients. To make it easy, because that's what it's about. It's about keeping things simple. There's no point in having a complicated system because no one will ever use it. It's got to be user friendly. As Lynda said, it's even our education resources, they're developed for the different levels of care, like the caregivers, the diversional therapists, the registered nurses, and it's developed on what they need to know.
No, absolutely. We love that. And I'll speak for myself, but I'm sure that I can speak for generally that ability to pivot and identify the specific needs, target those, and produce a solution that matches that is, yeah, it speaks to all of the opportunity that we've got and how we can achieve the outcomes we're looking for. Everyone, we do have just a couple of minutes left in our session today. So I would encourage anyone in the audience, if you do have any final questions to send through, you can use the Q&A function on Zoom or drop a question in the chat. Otherwise, outside of this, I'd love to just go around the group with all of the insights that we've gotten today. Were there any key messages that you wanted to leave our audience on today around this concept of digitization, making technology work for the sector to improve the lives of our staff and, most importantly, improve the quality of our care delivery and the lives of those for whom we're providing care? David, I might start with you.
Yeah, James, I'm going to pretty much repeat what you just said. I think that's the lens what you need to look through when you look at technology. How's it going to improve care? How's it going to serve our staff and provide better outcomes for our elderly people living across New Zealand and Australia? If that's the lens you're going through, then you start your vetting process from there. I think that'll be the key, the foundation, and I'll drill deeper. And then when I say drill deeper, does the technology speak nicely? Other technology, things like that can be following those. But if we come through those lenses of one, technology is to serve better care is the key foundation there. And I think Catherine said this really nicely, keeping in mind what we're trying to achieve, and this is the road. And as we all know, most straight roads driving on is pretty boring. There's always a few little bumps, but makes the journey more fruitful at the end. But if you look through that lens, I think that is the right way then to start unpacking what technology you need. That's a key takeaway from me.
I think if I can just expand from there, that and also enabling staff that if they do come up against a bump in the road or something that's blocking their way, to enable them to share that feedback or give them a strong foundation to come forward and share that feedback and not just remove themselves away from the technology even further. If they know there's a safe ground to fall where they can share the feedback and share the improvements that they ultimately want to see the technology key for them or help them deliver that better care, if giving them that strong foundation for them to say, hey, this is why it's not working for me. Can we do something about it? Will just help us reach that end goal in the end.
I think also it's really hard for some people to visualize what things are going to look like from a technology perspective. So that can be hard for them to imagine what the end result will look like. But providing they actually know what it is that they're trying to achieve, then you can work on the right solutions that are going to work for them. And it's really important for them not to be frightened just because they can't visualize it. That's what the experts do. They take your idea and they provide you with the solutions for that.
Right on. And Lynda, any final thoughts?
Just one final thought for me. It is really, as I mentioned before, it's around that sort of gradually then suddenly. And if we look at technology for around falls, moving from detection to prevention, that landscape has shifted quite quickly. So it's not that long ago, one of your options was to build all kinds of sensors into your floor at great expense and have to be in your room and in your foundations and very quickly. In actual fact, now there are more portable solutions that can be applied for an individual resident and moved around. And so, if you wait too long, you're not ready for the nimble and the pivot when the sector is ready to deliver it for you. So I think you've always got to have a strategy. You've always got to know what the next improvement or opportunity to solve issues is for you, and to be having structures, I think, especially in larger organisations and forums, to actually make sure that you are scanning the environment and that you are ready to embrace, and that other requirements around you are ready as well. And not that we'll be changing laws just individually in Summerset, we don't seem to have that power, but how can you start to think about, well, how will it impact on our compliance needs? How will we demonstrate our compliance needs out of it? Doing that kind of stakeholder assessment as you're working through, so that when the sector is ready and it's affordable and it's nimble and it's tested and something that's safe to embrace, that you're ready. Yeah. Would be my final comment. Right on 2 o'clock there. Look at that.
Absolutely. Excellent. Well, firstly, Lynda, Liz, Kath, David, I'd like to thank you all for being on our panel today. And more importantly, everyone in the audience would like to thank you so much for joining us. If you would like to speak to any of our panelists, so apart from Lynda, anyone on the PainChek and VCare side, please don't hesitate to reach out to us at VCare or at PainChek. If you do have any questions, please don't hesitate to email through. And of course, a recording of this session and a copy of our recent white paper will be delivered to all of you in the very near future. I will say thank you one more time. And if everyone can have a wonderful day, that'd be absolutely great. All righty.
Thank you.
Cheers, everybody, and thank you.
Thank you, everyone. Take care.
Thanks,
Bye-bye.
everyone.
Thank you.
Bye.